Now I'm going to go over the Ottawa ankle rules, which are used to determine the need for radiographs after an acute ankle injury. It states to refer for radiographs if there is pain within the malleolar or midfoot area, as well as any of the following. A, being the inability to bear weight both immediately after the injury as well as within the emergency department for 4 steps. And B, bone tenderness along any of the following areas. The first being the distal 6 centimeters of the posterior edge of the tibia, as well as the tip of the medial malleolus. The second being the distal 6 centimeters of the posterior edge of the fibula, as well as the tip of the lateral malleolus. And finally, the base of the 5th metatarsal or navicular bone. Now I'm going to be going through the test item cluster for patients likely to benefit from lumbar stabilization exercise training. This test item cluster includes the patient's age under 40 years old, which can be found either on the medical history form or your subjective portion of your evaluation. The second item in the cluster is a positive instability test, which is a special test within the objective portion of the examination. So I will demonstrate that test now. Will you please lean over the table here and hold on, and you'll instruct the patient to bring his feet together straight and rise them up off the floor. Okay, relax. You would ask the patient if he had pain with this. Then you will provide support at the problem segment area, and you will instruct the patient to lift his legs up one more time and relax. If the patient experiences less pain with my support, then that's a positive test. The third item is a straight leg raise greater than 91 degrees. I'll demonstrate a straight leg raise test right now. This is a special test, but it's also a functional test of hip, passive hip flexion range of motion. And this will be found in your objective portion of your examination again. And then also, lastly, there will be aberrant movement present. This includes the Gower's sign or thigh climbing, an instability catch, reversal of lumbopelvic rhythm, or painful arc of motion. Now I'm going to go over the test item cluster for a patient who would respond to spinal manipulation. The first 3 item clusters you can find within the subjective portion of your examination. These include the duration of the current episode of low back pain is less than 16 days, no symptoms distal to the knee, as well as the FABQ work subscale score less than 19 points. The final 2 clusters you're going to find within the objective portion of your examination, and this includes at least 1 hypomobile segment in the lumbar spine, as well as hip internal range of motion greater than 35 degrees, and I will demonstrate how to measure hip internal range of motion right now. And he has about 30 degrees. Now I'll demonstrate the McMurray test, which is testing for the presence of a meniscus lesion. I will now demonstrate the anterior jaw test to test the integrity of the ACL ligament. Now I'm going to be demonstrating the slump test, which is testing for sensitive neural tissue or altered neurodynamics as a possible source of symptoms. So I'm going to have the patient reach behind and clasp his hands for me, and then you're going to slouch down. Okay? You're going to kick out your leg for me. And then bring your head back up. Does that feel better?
Yes.
Awesome. That's a positive test. Now I'm going to go over the test item cluster for a patient with hip OA. The first three you can find within the subjective portion of the evaluation. These include the patient's age being over 50 years old, a moderate anterior lateral hip pain during weight-bearing activities, and morning stiffness lasting less than 1 hour after waking. The last two can be found in the objective, specifically range of motion testing portion of the evaluation, and these include hip internal range of motion less than 24 degrees or 15 degrees less than the non-painful side, as well as increased hip pain associated with passive hip internal rotation, and I demonstrated how to measure internal rotation previously. I'll now demonstrate the Gainsland's test, testing for pain of sacroiliac origin. Now I'm going to demonstrate the flexion, abduction, external rotation test known as the Faber. This is to test for the presence of sacroiliac region pain as well as for the presence of a hip pathology. Finally, I'm going to traverse through the differential diagnosis of a gluteal weakness versus an L5 radiculopathy. With a gluteal weakness, the patient will experience isolated weakness of hip extension, abduction, and lateral rotation due to weakness of the gluteus maximus, gluteus medius, and gluteus minimus. With an L5 radiculopathy, there will be diffuse weakness. An L5 radiculopathy would possibly affect not only the L5 key muscle action of big toe extension due to a weak extensor hallucis longus, but it may also have weakness shown in all three glutes, the TFL, the tibialis anterior and posterior, and the extensor digitorum brevis. The patient may also experience altered sensation around the anterior lateral area of the leg and on the dorsum and or medial plantar surface of the foot. Lastly, the patient will have a diminished L5 reflex, which is a medial hamstring reflex.